Okay, my name's Angela Garcia. I am the president of the ALPS chapter. I wanted to introduce Dr. Armstrong. Dr. Armstrong is a professor of surgery at the University of Southern California. Dr. Armstrong holds a Master of Science in Tissue Repair and Wound Healing from the University of Wales College of Medicine and a PhD from the University of Manchester College of Medicine, where he was appointed visiting professor of medicine. He is founder and co-director of the Southwestern Academic Limb Salvage Alliance. Dr. Armstrong has produced more than 560 peer-reviewed research papers in dozens of scholarly medical journals, as well as over 100 books or book chapters. He is co-editor of the American Diabetes Association Clinical Care of the Diabetic Foot, now in its third edition. Armstrong was appointed Deputy Director of Arizona's Center for Accelerated Biomedical Innovation and co-founder of its Augmented Human Initiative, which places him at the nexus of the merger of consumer electronics, wearables, and medical devices. Dr. Armstrong was selected as one of the first 6 international wound care ambassadors and is the recipient of numerous awards and degrees by universities and international medical organizations, including the inaugural Georgetown Distinguished Award for the diabetic limb salvage. In 2018, he was the 25th and youngest ever member elected into the Podiatric Medicine Hall of Fame. He was the first surgeon to be appointed University Distinguished Outreach Professor at the University of Arizona. He was the first podiatric surgeon to become a member of the Society of Vascular Surgery and the first US podiatric surgeon named fellow of the Royal College of Surgeons, Glasgow. He is now the 2010 and youngest ever recipient of the ADA's Roger Picaro Award, the highest award given in the field. Dr. Armstrong is past chair of scientific sessions for the ADA's Footcare Council and a past member of the National Board of Directors of the American Diabetes Association. He sits on the Infectious Disease Society of America's Diabetic Foot Infection Advisory Committee and is the U.S. appointed delegate to the International Working Group on the Diabetic Foot. Dr. Armstrong is the founder and co-chair of the International Diabetic Foot Conference, the largest annual international symposium on the diabetic foot in the world. He is also founding president of the American Limb Preservation Society, an interdisciplinary medical and surgical society dedicated to eliminating preventable amputation in the USA and worldwide. So that is Dr. Armstrong.
Holy cats, student Dr. Garcia. Angela, it's good to meet you, man. You can only, you don't have to read that again. That is way too much. But thank you. You can only be disappointed after that, all of you. But we're all a family. But gosh, anyway, hello. It's a pleasure to meet all you guys. And I've already given you all my slides, so I could probably just kind of sink back into podiatric sort of obscurity. But I can't because there's other people here to speak to, and I'm gonna. I guess titularly, I'm the person to talk to you about trying to bring teams together and building teams and building programs. And it's awesome that I have predominantly students here, and you women and men are all just tabulae rasa. And so it is just blank slates, which is awesome. But I'm really just focusing on teams and whatnot. I'm not going to give you any of these data and whatnot, but I've already given you slides. So I think that has some hidden slides there you can take and do with it what you want. Just pay it all forward. And really the most important thing is that we all come together and talk about this interdisciplinary society, which is really completely comes out of our clinic. And it is born and raised there, and it's what it's all about. And you guys are going to find it's just such an awesome time to be a toe doctor, a flow doctor, or even I think there's some physical therapists on here, DPTs. So you're going to see that. We're going to talk about this. We're going to talk about the toe, flow, and we're going to talk about go. How's that? So let's get rolling. If I can do it. Again, there you go. You can just ping me if you have any questions or anything, but I've already given you the slides. So you guys can just press mute, kind of dull, kind of just relax. You've probably heard a whole bunch of freaking Zooms already today. So just relax and go to sleep and focus on something more important. Although for us, I don't know what's more important. If you're interested in the humble foot, it's really an expression of humility, but looking after it, it gives you this great gift of perspective. If you're going to try to help people, at the end of this peninsula, right? It's pretty important not to do it on your own. It's impossible. I don't think any clinician is unto him or herself an island, and that's especially true when you're working on the surgical and medical aspects and mechanical aspects of limb preservation. It really taps a lot of creativity in a lot of different disciplines, and that's what we're going to talk about. That's really the big idea. But before we do that, just very, very briefly, you don't need me to tell you guys that foot complications they're common, they're complicated and costly. I'm not going to show you any data here. You can take it from the hidden slides, just grab them and look at it all. But suffice it to say now that someone that develops a wound now has about a 2.5-fold greater risk of dying that year than someone without that, all else being equal within diabetes. So just the wound itself shortens life. If someone, God forbid, has an amputation, their 5-year mortality, a paper actually we wrote while I was associate dean at Scholl. And actually, I think Dr. Wu, who's your dean now, was one of my first fellows. But we wrote a paper and then revisited it this year. But the revisited manuscript shows that 5-year mortality now is worse than all but the very, very worst cancers, pancreatic cancer, lung cancer, and high-level amputations, but also peripheral chronic limb-threatening ischemia, which used to be misnamed CLI or critical limb ischemia, and all these other things going down. It's really difficult. And looking after these patients is very, very similar to being in many ways like a surgical oncologist in a lot of ways because of that. But we don't talk about it that way. We don't treat this way with teams, and we really can't, and we should. And that's a whole different discussion. But it's what you guys are talking about now in this great organization you're getting involved in. You guys are all pioneers, really, and when we talk about ALPS. But look, as I said before, no clinician is unto her or himself an island. And the good news is that when you put people together in almost any permutation, and here on this call, on this Zoom, like the frigging millionth Zoom you guys have already been on. And again, I'm sorry, prophylactically, I'm sorry that you're on another one. But we have just world-class characters here. We have Bernadette Olivola, who you heard briefly, and I can't believe she came on. Now she's could be going home now, but she's a world-class vascular surgeon in your backyard and a great mentor for all of you that are interested in this area. And that I'm just grateful that she's here. And my longtime friend and partner in physical therapy is also on here. And that's not Stephanie Wu, your dean, but Stephanie Wolfel. And Steph is a leader within the American Physical Therapy Association. She'll chime in a little bit here and there, and she'll sort of shut me up and sort of set me straight, as it were. And she's going to talk about the go portion of the toe flow and go bit. But the fact is that however you put a team together, it really doesn't matter. In almost any permutation that teams reduce amputation, you can look at data across the world, really every inhabited continent, frankly, now from our unit, from many others. And you see now everything is pointed in one direction toward prevention. But the fact of the matter is, you guys, that there's probably better ways to put teams together than others, depending on where you are, depending on what the skills are, surgically, medically, mechanically, et cetera, et cetera. And that's kind of what we're going to talk about right now. And let's briefly sort of get into this. Let's talk about taking care of the toe, and then let's talk about taking care of the flow. And then we're going to mash all that up. And then we're going to upgrade from toe and flow to toe flow and go over the next few minutes. How's that sound? Let's do it. So this seems to be true, that when you take care of feet, that you prolong the life of the extremity. And this seems to be true. And we can look at this is a study of over 1 million lives from Sloan and coworkers from already 10, 12 years ago. And I was just actually working with my friends, one of my K mentees, T-Wei Tan, I was just mentioning him when I was talking to Bernadette earlier, is epidemiology. He has an epidemiology interest, but he's just a spectacular vascular surgeon. He and I were just analyzing, kind of reanalyzing these data in a similar size data set. And the data now are even more interesting. But the fact of the matter is, when you look at podiatry, if you see your podiatrist and then one other doc or clinician at all in that year, then your relative risk for a high level amputation goes down anywhere from about 20% to about 2/3 over 6 years. I mean, it's usually, when you talk about stuff like this, you're talking about a few percent change, and that's wildly significant. Here, it's just, you could drive a truck through the gap, that improvement, and it's just for taking care of feet. It's just really, really simple, and just looking after people like you guys are already being trained to do. You don't even realize you're being trained to do it now, but you really are, and you're going to have such a great opportunity on the toe side to really make a difference. But that's one thing. But what happens though if it's removed? I would just ask this question, and that actually happened to us in the middle of the last kind of peri-apocalyptic kind of crisis that many of us lived through, which wasn't very long ago for any of us, but that was in 2009. What happened back then, there was quite an economic funk at the time, as it were, and many Medicaid programs cut out, believe it or not, podiatric care care by podiatrists. Unfortunately, this set up what epidemiologists call a natural experiment. So that's like if like, God forbid, Chernobyl were to explode, right? Or you'd have some terrible accident. You could look at cancer rates before and after that and see the relative effect. Well, that unfortunately is how it happened with feet. And with when foot care was removed, we thought, this happened in the state of Arizona, we thought that what would happen with this population of many thousands of patients with diabetes is that maybe amputations would go up a little bit, but then they drop down because people would rally. Different clinicians would see the patients, GPs, maybe some specialists might do it. And FYI, that was not what happened. It was like so much worse than we thought. And I'm just going to share it quick with you. It ended up setting up what we call foot in wallet disease. And just super quick, right after the announcement of podiatry being removed, there was a 45% increase in 45% increase in hospitalizations over through the rest of that year for diabetic foot complications. There was a 22% increase in length of stay, another 40-something% increase in mean charges, and then what we call surrogate aggregate outcomes, which is a euphemism for sepsis, amputation, and death, that increased by 50%. So these people's feet really were killing them. And what ended up happening was when we reported these data, that this ended up changing funding for this in neighboring states, but it actually didn't change it for Arizona, unfortunately. And my Flomigo, Joe Mills, and I were in the governor's office at the time. It's a whole long story, but it was pretty great, crazy, kind of depressing, but ultimately uplifting story. But that's a different discussion. So anyway, by the way, I don't need to show this. This is for your right brain or your left brain or whatever. You just see this dramatic increase, and you did not see an increase in amputations over the rest of the country. So that's what happens when you add foot care. It seems to improve the life of the limb. When you subtract it, it seems to cause some complications, like I mentioned. So that's adding the toe. What about adding the flow? Well, revascularization appears not only to prolong the life of the extremity, but it actually may improve and prolong life itself, as it were. These are data from my old longtime friend, the late great Ennio Falia, just passed away a couple of years ago from Milano. But Ennio looked at, these data have been copied, or I should say, redone by a bunch of different people, Matt Young and others in Scotland and others. But you can see whether you're doing an endo or an open procedure, or you're sort of bivascular, as it were, it doesn't really matter. There's a net protective effect in terms of mortality if you improve blood flow to the extremity when it needs it versus if you don't. And that seems commonsensical, but these data just show that you see a net improvement here. So that's great. If you take care of the foot, take care of the toe, it seems to prolong the life of the leg. If you take care of the flow, it seems to prolong the life of the leg and life. So why don't we mash this up and make two great tastes taste great together. And that's about setting up a team. Stop smiling, Ryan Cruz, by the way. By the way, again, congratulations, Ryan Cruz, on your freaking PhD, man. God bless you. That is really awesome. And that's what we call the toe and flow model. We kind of nicknamed this in clinic somewhere. And we were at Arizona, but it really just puts both of these things together. And it's really two surgical specialties on one service. And what we have thought and found is we think this is kind of the irreducible minimum that you need to run a team, at least in the United States. And there are different things in different parts of the world. And you really can be agnostic about specialty when you go different places in the world where there are different surgical and medical specialists. But this seems to be the atomic minimum, at least here, and for you transalpine types. And so what we start with in our program is we try to have a single hotline, and we call that hotline a hot foot line. And so this is like the first thing you set up. So you sort of start from acute, because doing the urgent things is easier than doing the hard kind of long-term things like all these mass screenings and preventative things. So you start with the urgent stuff that we all care about, that fill up hospital beds, and then you start moving to less urgent stuff. Now, it doesn't mean that you have to do one before the other. You can do a lot of them at the same time, but this is the first focus in institutions. We think it works really well. So what we do, it's super simple. You just have one. We used to call it a pager. There was something you guys called a pager years ago. And in England, they call it a bleeper. What the heck, bleeper? But you guys all have cell phones. But what happens is there's one number to call. And as soon as that, if you're on the inpatient ward, or if you're a physician or a nurse in the ED, and someone has an atraumatic kind of lower extremity wound, this is engaged, and all of the triage happens internally. And the hot foot line is engaged. And then we say, well, what's dominant? We grade the problem according to a score that we call Wi-Fi. You guys are learning about that, many of you, I think, in class already. But we just say, is this an infection dominant condition? If it is, then the toe portion of the team is kind of the primary admitting clinician. If it's more of an ischemia dominant condition, then the flow team is the admitting clinician. But both teams of trainees and are seeing these patients together, are talking and rounding together daily for the trainees and throughout the week for the attendings. And then and then very often it's a combination of things. We don't have time to really get into this, you guys, but you guys will learn this more as you kind of get into it as clinicians. But then ultimately, once this is sorted out, then these patients, either the toe dominant condition, meaning the infection dominant, or the flow dominant condition, then the patient is usually discharged to a tissue loss or wound clinic, which is really the next step. But this really can be very, very helpful as we kind of move forward. And the cool thing is we start to see real change happening. And these were data that we presented years ago now. Well, it's 8 years ago. I can't believe already, where we saw at our unit, even that already had a pretty good limb preservation kind of focus. When pediatric surgery was added to vascular in the same team, there was a big difference, big change in high-level amputations, 45%, but that's not unusual. It's about average for a lot of these programs of 40, 50, 60% reduction in BKAs. But it was pretty cool that it happened at a center that already really cared about the problem. But then there was a big change. There was a reduction in urgent, reactive surgeries like amputations toward more proactive and reconstructive surgeries, like a Charcot reconstruction, or just a local pattern flap or an osteotomy and a skin graft, things like that. And what we also saw was a dramatic increase in vascular surgery volume, 70-30 endo to open, even though there was a big reduction in staffing at the same time at that same unit. So that was pretty great because it made all the people that care about this problem, from the people who pay the bills in the hospital and the university, all the way down to us that are taking in our patients, that we're taking care of our patients, really care about this. That's pretty great. That's for your right brain. This kind of was scaled up through 2 entire cities, actually, in just a couple of years ago now in Canada, in one province in Canada. And some colleagues of ours set up a limb preservation unit and had underwritten by philanthropy as well as Health Canada. And check this out, it's pretty wild. There was already you had 2 different cities, Edmonton and Calgary, very similar, not too far apart. And they had very similar kind of ethnicities, very similar age groups, very similar disease burden. And yet there was really quite a dramatic change away from high-level amputation and more toward more foot-level amputations, and what we call a high to low amputation ratio. And Ryan Cruz played a big role in some of that stuff when we were talking about high-low ratio when we were in Chicago many, many years ago, doing this through the VA system as well in North Chicago. So look, that was how you build the first part team, like the first Hot Footline portion. But now how do you build a program? Let's rapidly roll through this, and then we're going to take Q&A. How's that sound? Because this is like adult daycare for me, but I don't want to waste any of your time. There's still hope for you guys. So we're talking about building the team, but how about building a program when you guys get out there and go for this? Because you're all going to. Let's talk about that. And we're going to talk about quick. I know usually 3 because things go with 3s, but we're going to talk about 4s. It's like 4 time. We're going to talk about 4 steps to success. But we already mentioned one of those 4, so it's really only 3. So that you have to remember, really. And we've already talked about going from the most acute to the least. And we've already written this and talked about this in a whole bunch of different things. We sort of summarized it in this New England Journal technical review we did not too long ago. But the bottom line is, let me just get started. So first thing first, I already talked about the Hot Footline, blasting through this, look at this. But we talked about the toe and flow model, but what if now you could move from the toe and flow model and then you could kind of upgrade just a touch and sort of level up. And we've done this now since, thank God, we've had even more resources in Southern California. And that's led us to hooking up clinically with Stephanie Wolfel and Dr. Wolfel. And now we call it Toe Flow and Go, because we added in physical therapy. And that really has been just a big level up to help change and help our patients move through the world better. And ladies and gentlemen, Stephanie Wolfel. You there, Steph?
I am. Thanks, Dr. A.
Look at you. Wow, you kind of came in. Wow, like I like.
So I think, we're fortunate.
You doing okay, Steph?
I'm good. Okay, thanks.
Good.
So we're fortunate here in Southern California, and especially at USC, we have a very robust physical therapy wound care group. So we have about 10 of us that are specialists in wound management within our PT department. And we focus on the inpatient side and kind of this acute on chronic assistance with not only the wound management piece, but as you all are learning, biomechanics is such a huge part of what's going on with these feet. So looking at gait assessment, looking at what type of assistive devices the patients might need to be safe with their offloading devices. You put a boot on somebody, you put a total contact cast on somebody, and then you expect them to move about in their world safely. That's not something that everyone is able to just get up and do. So that's a big part of what we kind of do on this inpatient side of things.
And well, good. So that's the first part. That's the Hot Footline portion. And if you guys are trying to measure what you manage, if you guys ever do any research in this area, and some of you may, and I would certainly encourage you, you're in a spectacular environment to do that with Ryan and with Steph and everyone in Clear and, setting that up. By the way, Clear, Bernadette Olivola, is the Center for Lower Extremity Ambulatory Research. Yes, I came up with that acronym. This is all I do. I just sit around making acronyms. When you're of very limited talent and limited intellect, that's pretty much all you got, is maybe every now and then a little acronym. But that's up there at North Chicago, and you guys have it at your disposal, you folks at Rosalind Franklin. So yeah, make use of that. But anyway, Hot Footline. But then when the patient's discharged, after their infection dominant condition has been addressed and or their ischemia dominant condition, it's usually a combination, then they just have a wound dominant condition. It's a lot more straightforward. I mean, it's still very hard, but it's a lot less hard because now the dominant condition kind of on our Wi-Fi thing, when we're looking at our Wi-Fi settings with wound, ischemia, foot infection, it's just the W portion that's probably more of a dominant thing that we need to take care of. And that can be done almost entirely outpatient with little blips of inpatient stuff along the way when you're taking care of that. And again, the goal here is to sort out that tissue loss. And we are really aggressive in how we surgically debride these patients. God knows, just ask Stephanie Wolfel. I may have just sent another patient to her because I failed to get good hemostasis post-operatively on all of our patients are like our favorite patients. These are all like family members. But this is all a terrific interdisciplinary family when you're trying to heal these wounds. And Steph has a big interest in this, in tissue repair and wound healing, just like we do. And PT's role in wound healing clinics. Stephanie Wolfel.
Here, I think it varies a little bit based on what area you're focusing in. So again, we have our PTs pretty integrally involved in the wound management piece. But I think the other aspect is thinking about how these patients are moving, thinking about some of the disuse atrophy and things that can come with patients that are using offloading devices for a prolonged period of time, and what type of exercise program can we safely put them in when perhaps they are still limited weight bearing, but to kind of mitigate some of those functional losses. And again, I think that's where, regardless of if you are interested in wound management or not, as a physical therapist, there's still a huge exercise component to working safely with these patients.
And in addition to that, Steph, I mean, we also have, it's an embarrassment of riches. You know, we have occupational therapy, although she hasn't come in as much now these last couple of months during the pandemic, but we use OT instead of using our folks in behavioral health, like in psychiatry and psychology, because, you know, many of our friends in psychology are dealing with people who have suicidal or homicidal ideations most of the time. And it's so hard to get any of those folks anytime. But remarkably, OT have been spectacular in their training in looking after folks and getting people back to work. In addition to that, we have world-class nutritionists and dietitians in our clinic with Maritza Molina. And that is just really, really terrific. And she becomes like a member of these patients' family. In addition to that, we have prosthetists and orthotists from Rancho Los Amigos, which is a really famous kind of national rehabilitation center, kind of like RIC in Chicago, just down the lake from you guys, or up the lake from Dr. Olivola. And we have Rancho. I'm sorry?
Said it's Shirley Ryan, no.
Oh yeah, that's right. True. So all of that is really, really great. And it's just it's great to have all these people. It's where you kind of upgrade from just the toe and flow to all this other stuff that can really, really be helpful. Anyway, let's continue to rock and roll as we move through all this. Measurable goals here is really time to healing, plus those other things like high to low amputation ratio and length of stay. When someone's healed, though, they're really, are they really healed? Because 40% are going to have another ulceration in 1 year. With the best available data we have, 2/3 at 3 years, 3/4 at 5. And by the way, the same thing is true for vascular disease. There are more now, and there are more every year, but there are more reinterventions in North America and in the EU, really almost all over the world now. There are more reinterventions in vascular surgery than there are interventions. And so it's just like, just conceptually, it's the same thing on the toe side and the flow side. So these folks we don't use the word healing for these patients, although we do, of course, say, you know, thank God you're healed. But then we say, you're not healed. This is just like cancer. And when you say cancer, it freaks them out, right? But they've already heard you tell them about how it can shorten your life and blah 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 blah. And but then you say, when you're having the talk with them, you say you're in remission, and we say our goal now in remission is to even though it's almost certain you're going to get another wound or another vascular problem over our long collective life together, we want to make those problems as minor and as short-lived as possible. And here's what we're going to do. We're going to take you to the operating room if we need to. We're going to take you to, we're going to get you the right shoes or and insoles, et cetera, as needed in this, for your condition. And that's really the big idea as we move into these remission clinics. And this has been spectacular. Stephanie, I should say Laura Shin, my partner, and she's a Scholl grad. She was our first DPM PhD student back in the day. And I know Ryan remembers her really well. I know Stephanie remembers her really well. I think Steph was a fellow when she was just coming up, but Laura's with me now, and she trained at UPMC and then out with us, and she's spectacular. And she started this remission clinic that we have, and it's so great. And we can go after these patients with the right kinds of resources as we need them. And one of these resources really is for us, physical therapy as well. Steph?
So really the key here with remission, I think, is trying to extend those ulcer-free days as much as possible. And to do that, we have to find that right mix of activity. If we just have the patient go back to doing whatever it was they were doing that brought them into clinic, then they're probably going to recur much more quickly. So really finding that sweet spot when we're returning patients to activity and helping them to advance their activity, getting them into that custom footwear, helping them break that footwear in gradually, and then also doing that transition safely into different types of activity, and just making sure that we're really kind of monitoring that and also helping them select those activities. So these aren't patients that we want to go back to the gym and get on an elliptical, for example, because that's going to put a whole lot of plantar friction forces on their foot, which is not great for someone with diabetes. So
although there was a Scholl student back in the day, I've just forgotten her name. I'm looking at her face right now. She went did a residency in Buffalo, I think, but she developed a clear cleat with us that actually where you can clip in to a bike, but it's non-weight bearing. Do you remember that, Ryan? Yeah.
Yep, Dr. Klein.
Look at that, Aaron Klein. Look at you, what a memory. God dang, like a steel trap, Ryan Cruz. Mine.
Well, she's still affiliated with the school. She's got an appointment at Scholl right now.
What the heck? God dang. All right, see that? Oh man. But this is the kind of thing that Steph does. This is what she does, and it's so great to have this available. And as you see here, we've already talked about these kind of measurable goals. But let me just tell you something else. So if you're going to continue this sort of kind of analogy with cancer, this is a bit tongue in cheek. Ulcer, look, metastasis is not tongue in cheek at all. But we're just talking about extending the concept of this. Remarkably, after people heal their wound and they have that recurrence that I mentioned, only I think 80% now. Or more, yes, as it says in the slide. Look at that. I should just read the friggin' slide, shouldn't I? 80% or so from recent work from us and now from others, 80% occur in another place. So we're really taking our eye, not off the ball, but just maybe we ought to look at the rest of the body connected to that patient. Half of it is on the contralateral side. So there's just a lot of stuff to cover, even though it's just 2 little feet. So anyway, that's the third of 4. And here's the fourth of 4, getting these community screening clinics into place. And there's so much that we can do here to affect change. And back in the day in Chicago, we developed what's called the foundation of what is now called the American Diabetes Association Comprehensive Diabetic Foot Examination, or CDFE. And that turned into a 3-minute foot exam. And now that spread all over the world. And this is now from the NHS in England. They have like a green, yellow, red thing, and you guys probably do the same thing really in your clinic. But we can even apply resources to these patients as needed, and we have clinics designed based on these risk strata, or even an active problem, and then you can screen these people rapidly, and it does not have to be a therapist or a physician or a surgeon. It could even be an LPN or an LVN, whatever consonant you choose with the LP or the V or the RN or whoever to be screening these folks. And you can put them in these categories and get them back into the rest of those other pillars. And that's pretty cool. And what you see here is that the PT can play PT and group can play a significant role here too.
Yeah, this was one of the things. We have a grant here at USC that we've been working on this with. And this was something that we actually rolled out across all of our PT clinics. So even our PT clinics that are primarily seeing orthopedic patients. The reason that we kind of made this shift is there was an article that was published last year in the Journal of Orthopedic and Sports Physical Therapy. And it talked about the fact that about 80% of the patients that are referred to outpatient physical therapy are either diabetic, pre-diabetic, or they have risk factors for diabetes. So 80% is a pretty big chunk. And we're just talking about people that are coming in for, after a shoulder replacement, after knee replacement, ankle sprain, those types of things. On the flip side, only 2% of referrals to outpatient PT in the US are specifically for diabetes.
Yeah.
So that's a huge gap. So we incorporated this 3-minute foot exam into all of our USC PT clinics for any patient that has a comorbidity of diabetes. And it's been a real game changer for us as far as getting patients folded into the system a lot quicker, because it's just kind of a higher touch environment. And we're able to capture a lot of patients much earlier and get them in for preventive care, and also get them some really good exercise prescription to look at kind of managing their diabetes, decreasing their medication needs, those types of things.
And by the way, the PT can really help you fold these patients into your clinic, because they improve all that flexibility and stuff. Now I'm like a freaking yogi. I came in, I couldn't even touch my toes. Now I won't show you now because I don't want to, but you can wrap my leg. It's really pretty crazy. And thanks to, I owe it all to Step. So there you go. Branch out and do this, don't do this in terms of working with folks. Okay, we don't have to talk about these measurable goals. You guys are bored stiff about measurable goals, but they're important, again, because you can't manage what you can't measure. And that's the big idea here. What's pretty cool is that this has sort of led to some really great collaborations. And some years ago, we put together this sort of stairway. Like in plastic surgery, plastic reconstructive surgery, you'll learn you have like a reconstructive ladder, and you can go up from like, a free flap or something at the top, or like a cross leg flap or something weird and exotic on the top, or, all the way down to just, a healing by secondary intention. Well, we do the same thing in wound healing or diabetic foot and amputation prevention. And this is actually, I think, from Rutherford's book. We did put this in some years ago. But if you look here, for these things that we have to do surgically and medically, the toe and flow overlap really beautifully. And so that is what led us to create this many years ago. And this is going to kind of lead into ALPS, because many years ago, it caused us to say, that's in podiatric surgery. And then folks like one of my friends and colleagues, much less accomplished than Professor Olivola, for sure, Joe Mills. There's just a lot that's less about Joe Mills. He's not on the phone, the TV now or the Zoom to defend himself, but I don't have any internal monologue. But Joe and I, many years ago, kind of put some of this together, and he went to SVS at the time, and George Andros is one of my longtime friends, did that as well. And that ended up leading, do I have it? Yeah, it ended up leading just 10 years ago to this great like dual issue of, it was the first time ever in either journal's history there was a dual issue for anything, and it was on limb preservation. That's what we did in this thing. You see Joe's feet sitting in my office. That's right down here. I don't know if you guys can see the arrow, and then that's one of our patients having a BKA. But that's the cover of both journals. But that ended up leading to a lot of men and women training in this area over the years, and a lot of centers starting to bring podiatric and vascular surgery together at teaching institutions in the United States and around the world. But we also find that it's hard. It's hard to find, if you're a vascular surgeon, you're a young vascular surgeon and out in the community, how to find your toe amigo and vice versa. And then very often what ends up happening is you end up kind of, there's not this sort of interdisciplinary bridge. And that's why ALPS, really, you guys. And so you guys are all getting involved in this now. And it's really great. And it's already just taken off like crazy. And all of you obviously are already members, but you're so welcome to join. I think it's free anyway. Why not? But it's already now, we've already getting grants now we've already had a few $1 million in grants, either being coming in or now even being guaranteed. And it's very, very exciting to see this kind of thing happen with a not-for-profit. So it's a fun time to be working in this area because bringing this together is what it's all about. And you think by partnering up with someone, somehow you're lesser. And I don't know how that's possible, but sometimes people do, and they tend to be really closed off. But when you open yourself up and it's a force multiplier. I don't know. It's probably a poor terminology, but it really is. And 1 + 1 equals much more than 2, I assure you. And you already know the website, the Twitter handle, but you can certainly tweet at us whenever you like. Dr. Cruz is the founding secretary of ALPS as well, and he's really got it together. But you already knew that. What do I have now? I have a conclusion. So in conclusion, let me just show this. So I was, I don't even know what I have here, but it'll probably be pretty funny. Oh yeah, cool. So look at this. So when I was a kid, all the way through university, I played soccer and I was a goalie. And you can be a striker and be super fancy and capable and like everyone, like the most popular woman or man on the team, because you can take 20 shots, miss 19, and you're like the friggin' hero. The inverse is not true in the goal, and you can you're not the hero, you're not the GOAT, but you are the GOAT, but not the greatest of all time. You're the worst of all time, and for whatever reason, I always kind of gravitated toward the goal, and then I found myself like in a great specialty like podiatry, where I kind of felt like, hey, that's kind of like me in clinic too. So, but I saw this video and I wanted to share it with you. And let's see if it plays here. Yeah. So, but yeah, there we go. So, oh yeah. And when I saw this, I immediately thought, I started laughing. I picked myself off the floor and I thought of this great quote from Mason Cooley, who said, because I said, man, that's me in clinic, in kind of a dumb, just looking dumb, looking like a fool, but somehow still coming up with a humble save. And Mason Cooley, not Denton Cooley, but Mason Cooley came up with the aphorism, came up with this great quote. And he said, if you position yourself well enough, circumstances will do the rest. And I believe that. And if we come together, it's just putting ourselves into a better position. And it's so much more fun to share this kind of thing, failures and successes, with your patients and with other folks. And I just tell you, it really is worth it. It's harder, but we have a saying that hard things are hard, and it doesn't mean it's not fun. And it doesn't mean it's not worth it. It doesn't mean, ladies and gentlemen, it doesn't mean that it's not worth a life's work. So for real, and you guys, it's such a pleasure to meet you all. You guys are so welcome at our place. And thank you on behalf of Swolful, Dr. Stephanie Wolfel. It's just such a pleasure.
Okay, so thank you, Dr. Armstrong, for that, and Dr. Wolfel, and we have Dr. Alivola here. If anyone has any questions, you can go ahead and type them into the chat and we'll relay the questions to them.
You can, people can probably come off of mute if they want to as well. They could, I mean, we're only here as a family, but okay, whatever. People want to type it in as well.
Either one.
Yeah.
Well, I have a question. And yes.
Oh my
And this
gosh.
might be,
Doc-
I know,
yes,
it's-
yes.
and this
Yeah.
may be a silly question, but I'm kind of curious if you have, like a non-compliant patient. Like, for example, you have a patient, you heal
We
them.
like to call it student Dr. Armstrong. We like to call it non-adherent because
Excuse me,
complying
non-adherent
with
patient.
things is like you're ordering someone to do something. I'm trying to be more touchy.
Non-adherent. Okay. Okay.
Okay.
You have a non-adherent patient. They go through toe, flow, and go. They're in remission, and then they basically drop off the face of the earth, right? And they come back, a few months later, they're reulcerating, and so they go back through the whole process, drop off again. At what point do you intervene and just say, like, hey, like, have a little heart to heart, to try to prevent that from happening again?
Well, that's a great question. Well, I wanted to bring in, Ryan, Dr. Cruz has spent a lot of his career doing things like this, but I'll start by not asking Dr. Wolfel, but or Dr. Cruz. You can chime in, Dr. Cruz, but I'll ask Dr. Olivola about this too, because I'm sure you have, many of your patients that, classically for a vascular surgeon maybe won't stop smoking, but that is like such a small thing now compared to the big thing, which is all the other bits and pieces with diabetes and in limb preservation. You want to chime in, Bernadette?
Yeah, I think there are lots of different components of limb salvage that really make it important that the patient engage in that process. So you need the patient to buy into all the things that you're recommending, including the multidisciplinary part of the approach and understanding why all of the specialists involved, their recommendations are crucial. And some of the recommendations that we have, or the ideal of how to perfectly manage a patient will not happen as you would like, right? So you sort of have to, I don't want to say compromise, but you have to be somewhat willing to accept that. Go ahead. You want to jump in there?
That's like no, Bernadette, that's like wisdom right there. I mean, it's this is so hard to articulate, but it's like marriage, right? It's give and take, and this is like your therapeutic spouse, right? And we always try to tell them. Everyone has a kind of a version of this, but I always tell my patients, I don't want to be doing things to you. I want to do it with you, and I think people feel that. They know when you really care, and they know when you're just sort of dialing it in. And now there are some folks that are not going to be, that are not going to do their part on the two-way or multi-way street. But that doesn't mean you can't, you can't keep trying. If you're going to, if you're gonna, I think people know, and I think that's the answer to this question. There's just so much that you can do. Almost always, ultimately, you can get through to someone 99% of the time, but there are patients where it's really, really hard. I see Adam Fleischer there. Go ahead.
I was gonna say, I think something that's worked for me in the past too is to just be really upfront with the patient at the beginning that this is a process. Like, we are not done when your wound is closed. We are not done when you get your footwear. We are not done, I think just to prepare them and help them get in that mindset that this is going to be an ongoing, relationship that we're going to have. And sometimes you're going to see us more often, and other times you're not going to see us as often. And that's great. We're going to, change that to meet where you are within this timeline. But then also help them to see what elements of this they have control over. Chronic wounds are hard because patients feel like they lose a lot of control. They're slaves to this coming to an appointment 3 times a week and having to do this, and I can't eat this, and I have, there's all these things they just feel like they have to do. And I think we would all say that it's pretty normal human behavior to not want to live in that very structured space all of the time. So I think just giving them, for me, I try to give them, what can you do to impact change on this? What can you do to make the healing go a little faster? What can you do to have better control over your diabetes? Yeah. And I think Dr. Olivolo said, they may not sign on for every single thing that you consider the gold standard, But if you give them a couple of exercise options and this is the one they feel like doing, great, let's work on that and start there. And then hopefully once they start seeing a little bit of change or a little bit of progress, they start to buy in a little more. And then you can kind of foster that relationship.
That's right. And Ryan, Ryan's, a lot of Ryan's career has been, in fact, I think a lot of his PhD was in looking at adherence to something that we always talk about, which is offloading a wound, protecting a wound, something that's seemingly simple. We actually now have an NIH grant where we are randomizing people into a kind of a punitive offloading device that you can't remove. These are people with tissue loss. And then we have one that you can remove. And then we have a third one that you can remove, but it's smart, or smart in quotations, but it gives feedback to the patient. It says, "Hey, Ms. Garcia, hey, Mr. Jones, that boot that we have for you is sitting next to your Barca lounger, and it's acting like a beer cozy. Maybe it ought to be on your leg." Well, it doesn't quite say that, but it says something like that. And it coaxes people into better adherence. And the question is, will that improve healing? And that's just another kind of process. So you have that, and there is no answer to this, but this is definitely your therapeutic spouse. And the really cool thing about podiatric surgery and vascular surgery, these are two specialties that are really complementary because they both follow people. And it's unusual in a lot of specialties, like surgical specialties, to follow people from the alpha to the omega, from the beginning to the end. And it really is like in vascular, you talk about just complete vascular care where you're looking after people the whole, or comprehensive, whatever the terminology is now, but it really is all the way through. It's the same thing with us, and we're seeing people that we know we're never going to take to the OR. And then we're seeing people, where we're taking them to the, where we've taken them to the OR, quite a lot. And so it's ultimately super challenging, but really, really gratifying. That's a really actually excellent question.
Well, thank you.
You've mentioned my name twice now, David, so I feel obligated to say something.
Yeah, well, listen, don't listen. No obligation required. No purchase required.
I just want to.
Look at you with is that like a gaming headset? What's going on there, man?
Yeah, I sound a bit clearer this way. I'm a low talker, a soft talker. You're
a close talker as well.
I am a close talker. You know that. I spent a year of my life at Loyola, and I see Bernadette, you're at Loyola now. So I am curious. I mean, in theory, this works wonders. And I know at USC you're putting it into practice and maybe getting funded to do it. But what is happening at Loyola? I mean, do you guys have something like a Hot Footline? Would you say? The Hot Footline that you described is about as close as I can imagine as something truly interprofessional. Truly not multidisciplinary, which is two disciplines, writing their own notes, write their own opinions, and then somebody kind of being the arbitrator or whatever. You basically, it's truly people at the same moment in time collaborating, on a pathway or a plan for that person. So it's exactly what RFU kind of stands for, is IP education, and so I think it's a perfect model for what we're trying to do, at Rosalind Franklin. But I'm curious how much success other places at big academic institution like Loyola. So, what are you guys doing there?
That's a good question. And I think there are a lot of logistic issues, as Dr. Armstrong is well aware of, in formally integrating, multidisciplinary team. Here at Loyola, our podiatry group is part of our Department of Orthopedic Surgery and Physical Medicine and Rehabilitation, and the podiatry group as well. From a structural or practice standpoint, sitting in two different departments in an academic medical center, I love Dr. Armstrong's input in terms of the process of merging different departments. It's not straightforward. in our setting, our toe and flow program is essentially a virtual program. I have all of my podiatry colleagues' phone numbers on speed dial, so
Yeah.
so we cross train. So we have the podiatry trainees rotate with our vascular group. We have almost daily interchange on patients we have in common. We have mechanisms for quick referral and evaluation of patients. So let's say our podiatrist sees someone in the clinic and they've got a foot that's dysvascular. They think one of my group needs to see. If they go the route of sending the patient through a central scheduling system, that'll never work. So they basically have a direct route where their team and my nursing team are in direct contact to expedite patient evaluations. Also, part of it is just a common practice in terms of the steps of evaluation. So, the concept of coming together with, formal steps for evaluating so that, as Dr. Armstrong mentioned, the components that we put into the Wi-Fi score are considered formally in every patient with a foot wound. So obviously the patient population that we see is a subset of the podiatric patient population. And on the flip side, the limb salvage patients are a subset of what our vascular group would see. Those patients that come together and sort of cross those areas where we're talking about limb salvage, we have a pretty defined algorithm for the workup, which includes, arterial non-invasive studies, formal evaluation for infection and getting infectious disease involved and that type of thing. It would be difficult, challenging to physically bring those teams together on a single, sort of service. So maybe Dr. Armstrong can elaborate on the ways that you navigated through those in a system that's very,
it's right. Well, all this stuff
structured.
is, Bernadette, man, you just articulated, you didn't disarticulate it. You articulated that really, really well. This is hard. Medical schools, especially, but just hospitals in general and medicine and surgery in general are super, just super parochial and conservative by nature. And a lot of it's necessary, really, because you don't want to be doing crazy things all the time, but it's parochial, it's conservative by nature, and it's sort of sclerotic sometimes, though. I mean, really. And sometimes you have to, do a big freaking kind of administrative atherectomy, as it were, what happens is when you have two different specialists on in different departments, it can make it really, really complicated to put them both together because there's like different budgets and different line items. We have felt and we have found that ideally podiatric surgery does not belong in orthopedics. It exists in orthopedics. And look, I have so many friends I've trained. I've forgotten how many orthopedic surgeons I've trained. And many of them are friends and mentees of mine over many, many years, just like bunches of plastic surgeons and vascular surgeons. But it does not belong in a department, ideally, in a department of orthopedic surgery. It was there because historically, when women and men came in podiatry into places and like Loyola, and they were like the first of their breed, they didn't know where to go. So they figured, oh, bone surgery must be orthopedics. And the orthopedic surgeons said, yeah, we have no idea who these people are. Let's keep control over them. And so that's kind of how it grew. And it's not because of any evil cabal. It was just because of that historically. But that's not where it belongs anymore. You don't have necessarily hand surgery. You don't have plastic surgery in orthopedics. You don't have neurosurgery in orthopedics. It's different. So it is a surgical specialty, and it belongs, I believe, in terms of being elegant in a department of surgery. But historically, you sometimes have to just work through that. And it's not working against someone or with someone. It's just working toward what's best. But sometimes you start by just hiring one other person into your department, and then growing it that way. And then it just sort of grows into that kind of thing. And then it just merges, or a whole variety of other things like that. Did you guys hear me?
And part of it too is, I don't know if you work alongside orthopedic trained foot and ankle surgeons, but we have, our foot and ankle specialists that, oftentimes are caring for patients that are overlapping in terms of clinical presentation to what our podiatry group will care for.
Yep. And all that's great too. I just say the more the merrier. You have Mickey Pinzer, I think, and I've known him for a long time. If he has an interest in one area, it may not be in everything. I think the problem that people get into is when you have something like when someone says, well, I don't do that, limb preservation or whatever, but you shouldn't do it either. When that comes up, then that's wrong. And sometimes that happens just because something new comes into a facility, and that can be addressed directly ultimately. And the way that happens is just, by clinician to clinician and facility to facility, and, based on someone's level of training and credentialing and that kind of thing. It ultimately, if you make it about the patient and you don't, this is such a great question, Adam, because if you make it about the patient and you don't make it about like what your specialty is or not, or isn't, or whatever, then you're ultimately going to win. You may disagree with some things that happen, you may agree with others, but ultimately you're going to win. And you can make yourself almost blind to agnostic to specialty and training, but yet you can be evangelical about looking after patients. And by the way, on the flow side of things, not just on the toe side, is actually relatively simple, because now podiatric surgeons have evolved to do this now around the country, around the world. And they're really, it's become really, really common. On the flow side, you have all kinds of other issues as well. You have interventional radiology to some extent. At some places you have cards, interventional cardiology, and they're kind of throwing stents and doing things, hanging out down in the cath lab. Some are doing great work. Others are not working as well within a team. But what's cool is when you can put all of those vascular interests, or even interventional nephrology, into some of the things, into a cogent whole, then this is what I'm Bernadette, I think, probably does constantly, as chief of her division. That happens in every discipline. And what should matter is, do you care about the problem, and are you trained to take care of the problem? And when you do that, then you don't even have to worry where you are, and it transcends borders. Great question.
Thank you for all that. I just wanted to make the reason I decided to tune in today, because I've heard the toe and flow, and if there are students that have questions, don't let me take up your time. But the go, I think that is so slick. If you want to add one more person into your Hot Footline team, whatever that is, maybe it is PT, your physical medicine and rehabilitation, a physiatrist or something like that.
Yeah, PM&R too.
Who will know what level they would do well at potentially.
Yeah.
So that everybody knows what the end goal is as soon as that patient hits the door. I mean, I don't, that's just a thought, but I think that's a slick addition.
Well, thanks, Adam, man. That's real wisdom. And, Steph can speak to that. But she came up with the toe flow and go at the exact same time that one of our other trainees in Houston came up with the term. I think it was at DEF CON or something like that. But Miguel Montero Baker, who's one of our old residents, he's just a great, gifted vascular surgeon in Houston, that works somehow. He works with Joe Mills, my old friend, and he's still there. But they're Miguel came up with the thing as well. He asked the question, why don't we work more closely with physical therapy and call it toe flow and go? But Steph, you want to speak to that?
No, I mean, I think it's been a great
No, you don't want to
just
speak to it?
addition with the clinic. Well, I mean, I'm agreeing with what everybody's saying. So I don't know that I have that much to add, but I do think it's been a great addition. I mean, you know, Dr. Armstrong, Dr. Rowe, who's our vascular attending, and I, you know,
Flow
we
row.
go in the room together and we have a conversation about the patient and what's going on and what do they need. And if we're getting to the point where we're talking about a lower level amputation, we can talk through and kind of discuss the functional implications of that right from the start and have a really good plan to get that patient rehabbed and in a way that's going to be, you know, functional for them long term, not
Yeah.
just something that is gonna, you know, kind of get them out the door. So I
Yeah,
think it's
and
been a
you're
really
moving-
good collaboration.
And you're moving forward, right? And you're all in there together in the room, which is great. And we have prosthetics and orthotics in there for really creative efforts along that. We're prehabbing people, and we're pre-fueling them with nutrition as well. And when you bring folks like that in, and you figure out a way. That's the other thing I think that Dr. Olivola thinks about constantly is, well, how is this going to work, in terms of fiscally and there, you can do it and you can do this. And it's amazing how if you generate a little bit of momentum and success, that this really can make a really, really big difference.
I could throw out one question. I know we're running a bit long here, but
Sorry, man.
no,
No, by the way, I'm sorry to
I'm
all
happy
you
to
guys.
stay on.
Yeah.
We have allopathic medical students. We have podiatric medical students. I think we have some physical therapy students on the line here. We've talked about some of the challenge from payers as well as administration of getting some of these specialized units together. As practicing clinicians, do you have any tips for these students as they start going on rotations, or maybe when they get to residency, some incremental improvements they may be able to kind of push through as they start going out into different areas of the country?
Wow. Hey, Steph, you want to answer any of that?
Yeah, I mean, I think for my PT colleagues, I would really say, I think our impact from a screening perspective, I think, is the biggest place that we can make impact. So just thinking about, regardless of what your patient is coming in for from a PT perspective, if they're diabetic, you need to be looking at their feet. And we need to be finding those colleagues within podiatry, within vascular, search out the folks. If you're in different areas of the country, it might be different specialties, but search out the other folks that are working within kind of this limb salvage arena. And don't feel like from a PT perspective that you need to figure it all out. You just need to know who your resources are. And I think you can start that networking as students. This whole ALPS student group, I think, is amazing for that perspective alone, in that it gets these different disciplines together early on. And I think the more you network and understand what these other specialties do from a student perspective, it's going to help you as a clinician know how to, speak the same language and kind of start building your own team. So
yeah, and you're not,
I
and
think
you're
from
not
the PT perspective, the screening part.
That's it. And you're not like the other, I mean, it's not like, that's the trouble, you guys, is that there's this trend toward, it's entropy. It's a freaking law of thermodynamics. There's a trend toward disorder, and there's a trend toward just, a big chill, and all of us as little particles, little insignificant particles floating farther and farther away from each other. And the only way to fight that is with energy into your system, your physical system. And it's true, I guess, in physics. It's true in what we do in taking care of people. And it's the trouble is that when you're farther away, that person looks more different from you. And when you put energy into just going up there and, putting yourself out there, and with me, I don't have much of a internal monologue, as you can tell. And I certainly don't, I'm a relatively limited middling kind of ability. So I just go up and ask for help, and you'd be amazed at how awesome it is when you do that. You just kind of put yourself out there, and that includes, by the way, also I know it sounds crazy, but look, even administration, God forbid, in your hospital, working with them, and it really can, you really can make a difference. And we have a really close working relationship with leadership in our institution, and now we're having a new Steve Shapiro is coming out now. Steve is coming from UPMC. He's a pulmonologist by training, but he's our new kind of Uber Dean, Senior Vice President for Health Affairs. And he's coming in now looking after, he's going to look after, and we're probably going to buy a bunch of new hospitals in this area, just like it in Pittsburgh. But you'd say, well, toe doctor, how good a toe doctor? Well, I mean, just like anything else, it's a friggin' meritocracy, right? And, it's what's great about academia. You show up and, you do the work, and sometimes it's not a meritocracy, but most of the time it is. And you do the work, and that's what gets you in. But, your degree and training should define you. But it should not confine you. You got me? And so that's the big idea. And if you don't, and it's where you come from, and your training, and it's what makes the whole thing rich. But it shouldn't stop you from doing stuff. And it's okay if you look dumb. I mean, just come back for more, just like that goalkeeper in that video.
One other thing I would say too is don't underestimate the value of like downstream revenue. So when you're thinking about how do you, maybe pitch an idea like this, or talk with folks about it, because from the PT perspective, depending on if you're in a licensed or a non-licensed clinic space with your physician counterparts, that impacts some of our ability to do some of our own billing. But I know one of the things that we track is I track referrals to our outpatient wound care clinic. So that's a direct result of me being in clinic with the physicians. We got 4 referrals into our outpatient clinic yesterday. So that's going to be an average, I know how many average visits we see those patients for. So I can calculate out what that downstream revenue is from being involved in the clinic. So there's other things that you can use to kind of talk the talk when it comes to administrators and that type of thing too.
And everywhere you go, and as you guys go out there, things are going to change as well. And you'll find that different folks need different things, and you just have to find out what it is that she or he needs, and what's their kind of, where's their kind of pocket of resources. It could be a health minister in a country. It could be a department chair. It could be a dean. It could be and all these people have different kind of angles on your big Venn diagram, but your Venn diagram ultimately should look like a bubble bath. There's just all these overlapping circles, and everyone kind of working together, and that's kind of lifts. So anyway, there you are. That's great, Steph.
Do we have any closing remarks from our student leaders here?
Well, I wanted to say thank y'all for taking the time out of your day. I know we ran a little bit over.
Thank you all. Hold on. Where are you from? Wait, where were you from? Did we already talk about this? Yeah.
So I got used to you all because everybody calls me out from Texas saying
Yeah.
y'all.
Yeah. Okay. Got it. Okay. Got it. That's right. That's right.
I always have to type it in on emails as you all.
Good
So,
idea.
but thank you all for
The whole other
taking
country.
time out of y'all's day, and we really appreciate it. This was awesome. And we would definitely love to do this again sometime in the near future. And we really hope ALPS gets out there nationwide. And that's
Yeah.
what we're
Yeah.
trying
Well,
to
you are the first of your species, and it is so great when you can do that to get this out there and get the ball rolling. It's happening. It already is happening. But you can make this what you want because it's yours. I mean, the way I look at this, Angela, is, you're already our colleague. You just don't know it yet, and there's a few more steps you have over maybe another decade or so, but you're already there because, we'll turn our head around and you'll be all grown up. So that's the goal. And coming into something like this, you can really affect change. I mean, super positively, and it is just inherently good. It's just an inherently good thing to do.
Well, thank you very much. We really appreciate y'all's time. Does anybody else have any last questions? Okay, well, I guess this concludes our night, but thank y'all very much and we really appreciate it.
All right. Thanks,
Thank
Dr.
you.
Wolfel. Thank you.
Thanks, everyone.